we need.
Yeah. So I could be wrong, but for me it's about the hollows. If you've got hollows that aren't complicated by too much edema or too much fat pad protrusion, that is probably more suited to an aesthetic medical approach. And when it starts getting complicated and you start moving from grade 2 into grade 3, you might at the very least need a plastic surgery opinion.
So would you say O'Sullivan 3 is definite indication of surgery?
No, not definite, because filler can sometimes do the job even in a grade 3, but to do the best for our patients, sometimes you need to get a plastic surgery opinion. And it depends, you have to be careful about the plastic surgeon. Somebody like Pat Sullivan, who's doing the transconjunctival lower blephs, for a younger patient is often the way to go. But I think when you're just dealing with hollows, aesthetic medicine, you can feel fairly comfortable. It's when it starts becoming complicated with either edema or a malar mound, I think is the other big complication, in addition to fat pads.
Sure.
In terms of the upper eyelid, really, I was talking about Morelli classification is probably the more useful, and it's Morelli type 2 and 3 definitely is going to benefit from the volumization, and that's because you haven't got the lax skin. So if you've got no excess skin and there is that hollowing, that you're going to see a good outcome from volumization. But when it comes to when there is excess skin, I probably wouldn't try as a beginner to inflate or add anything to it before they've had the excess skin removed by plastic surgeon.
Sure. I always thought that the A deformity is an ideal indication for injectables because it's a specific area, like only one. You don't have to fan. You don't have to kind of like distribute the product in area damaging the molar or the kind of levators aponeurosis. So why do you think they kind of did not recommend it in the paper? Is there any explanation?
I think they said the patients were satisfied, and it's all subjective, of course, but the assessors didn't feel that it gave the same improvement as it did when they've done the one that has hollowing all across, and probably because you can't give a smooth line if you are just inflating a small area comparing to when you're inflating across the whole deflated arc, if you like, rather than just inflating a small area. But I think personally it gives us great results from all the pictures that they've shown. But it's again a subjective assessment really.
Gerardo, is there any red line?
Yeah, as I said in my presentation, there are only a couple of things that could prevent you to use the aesthetic medicine in the correction of the lower lid aging. One is the skin laxity, and the second one is the skin, the thinning of the skin. If the skin is really transparent, you cannot use hyaluronic acid to improve the transition between the lower lid and the cheek, which is the main point where the tear throw is visible. So in my experience, as I say, Charlotte, I can also treat patients with a class 3 deformity. The most important thing is the sagging of the midface. If the midface is really sagging, even if you go and correct the tear throat deformity, the patient will not improve too much. But a complex approach, which means treat the creepy skin using the laser, treating the crow's feet with Botox, inject immediately suboperiosteal the hyaluronic acid to avoid any complication like the malar edema, can be a fantastic approach and can do wonders even in a class 3 patient. So this is my humble experience. Thank you.
Both upper and lower. If there is any red line to go directly to surgery or consider fat or hyaluronic acid.
Yesterday you gave me probably the most important insight that we all should share with students and beginners, intermediate, etc. That is the comfort zone. Where is my comfort zone? Example, as Mr. Nasser is here, when I came back from my training, I used to do rhinoplasties, but during the 4 first years, I didn't dare doing an osteotomy. So whenever I had a patient who needed osteotomy, I would just say, I don't do it. And it took me 4 years and other courses, plus my training, to get to that comfort zone. So it's exactly the same thing. Here, upper lid, it took me probably 9-10 years to understand, and that was with fat, to understand which patient I could enhance the upper lid and immediately remove some skin, because whenever we are enhancing volume, we need to remove less skin, the resection is less. But at the end of the fat grafting, everything is with edema, so it took me really 9-10 years to start saying, okay, I'm going to do it now. During the first 9 years, I would do it in a secondary session. So this is to say that it's very important to know where is its own comfort zone. I have a question, for example, for Bashar. You showed very correctly the A-frame deformity, and it's exactly where we have the supraorbital and supratrochlear arteries, and we need to inject there. Okay, so where are you going to inject? And you said you are going to inject against the periosteum, which is correct. I inject, but imagine you inject inside the periosteum and you entered inside the foramen. So what is the comfort zone? For me, the comfort zone here is adrenaline. Again, I needed, this key to be brave and dare and say, okay, now I believe that everything is shut down. I will go there. So it's really a question of comfort zone and not how do you say surestimate, not subestimate, overestimate itself's capacity.
That. What effect does filling behind the eyebrow and using filler to project the eyebrow, what effect does that have on the upper lid? Because some of the Italians were talking at one of your meetings about this a couple of years ago.
It depends once again on the indication. Injecting behind the eyebrow, right, is extremely useful on patients who have, like Mr. Nasser said, a negative vector. Patients who have the slight protrusion of their eyeballs. When we inject behind the eyebrow, we are projecting, actually we are advancing the skull. So it's the same thing than injecting here. So those patients, yes, it's perfect, it projects it and it pulls the skin of the upper lid.
So it has an effect on the upper lid?
Yes, but on patients who have deep set eyes, that shouldn't be done.
Yeah.
Because it will make the eyes even deeper, we will have less light reflection, and I had to go through my own failures to see that those patients really should not be enhanced.
There are quite a few questions in my own mind in relation to treatment, but we will leave it for the treat. I really like your, Fahad has came up with this analyze, avoid complication and treat, and I would like to stick to the system. So we will have another go at asking about technical aspect of treat this. So in relation to analysis, anybody have any questions or queries for analyzing the periorbital area? Professor Wang, I think, left to spend some time with his children, so eyebrow also included. Yes, please.
There is a significant number of patients coming with this complaint about the deformity in the lower eyelids. But it is not only laxity or deformity, they always, or this significant number, they have pigmentation problem. I mean the dark circle, sorry, the dark circle. So according to your experience, when you treat a patient with this deformity, is there any enhancement in this pigmentation? I mean, when you treat the deformity?
Thank you, Walid. I think we will cover that area in the treatment, and Suad has